I will show you today all the situation when we didn't know what the real diagnosis was and the OCT wide field had an answer. Advantages of wide field OCT come from the B-scan, the wide field angio-OCT, and the anterior segment view. Let's start with a very common situation, floaters and photopsia. So the patient comes complaining, and we can see only on the SLO image the projection of the shadow of the floaters and not on the color view. The big question is, are there retinal breaks or detachments? So we can scan with the OCT in the periphery, and we will know for sure if we are missing even very small breaks and lesions. So this patient goes out of the office with the diagnosis of floaters and posterior vitreous detachment, which is confirmed with the OCT. But this diagnosis, posterior vitreous detachment, is very common and very mistaken most of the time. Only ultrasound and OCT can diagnose for sure. Look at this patient. He has history of trauma, a previous laser on a retinal break. He comes with the new symptoms of floaters after a new trauma, and on the color picture we don't see anything significant. We could check with the contact lens. We know it is not easy as far as compliance of the patient. And we can see very well on the SLO image the projection of the floaters. So how many of you would diagnose floaters and posterior vitreous detachment? It would be very easy to conclude this consultation with that diagnosis, but the OCT wide field shows the floaters, but also that the vitreous is completely attached. So this is the scan in raster mode on the lesion. We can exclude with certainty any open break, and the other eye shows floaters and vitreous attached. So we know that not all the patients with floaters have posterior vitreous detachment. It is important because when the vitreous is attached, we know that we have to follow the patients even more carefully, because in the moment the vitreous detach, then he might have troubles. The beauty of the situation was that the patient went to the office and I was not there, and my orthoptist took the exam. I could check the exam from remote. So this was a great example of telemedicine, which was possible because of three factors. So the skills of my technicians that knew very well how to check the patient, the remote control, and also the ability of having a machine that could scan not just the periphery, but also not just the posterior pole, but also the periphery. So let's see some example of effect of posterior vitreous detachment. She comes with minor complaining of blurred vision. Vision is 0.4, and we can see from an old OCT that she has a vitreofoveal traction and an impending hole. Could we have more info from the periphery? So let's see, the wide field OCT shows the vitreous is indeed detached at the posterior pole, but attached at the papilla and anywhere else. In 3D, we can have even a better panoramic view of the distribution of the vitreous attachment and detachment. So I advise the patient just to wait because of possible spontaneous improvement, which comes a few months later with a complete restoration in vision. And as you can see, the vitreous is still attached where it was before. So the wide field lesion cannot be seen the OCT wide field can see lesions that cannot be seen with other instruments. This young patient comes with no symptoms. It is just for a regular check. The other eye had been enucleated for complication of multiple surgeries. Everything seems okay, even at the wide field scan, but he has a staphyloma, and the staphyloma is not visible in the color view. We can see actually esquisses into the deep sides of the eye wall, which is even more visible in the 3D view. And also we can see in the periphery a shallow retinal detachment, which was completely missed during the photo. And in the periphery, we can see a shallow retinal detachment, which was completely missed in the color view. And also a small retinal break that I try to localize on the SLO first and then color to be able to treat. So that was a case when the wide field OCT could see a threatening lesion with a silent retinography. Let's now see a case with when the OCT showed that there was no threatening lesion. Let's now see a case where the wide field OCT showed no threatening lesion with the threatening retinography. So this young woman comes with no symptoms. She has a 20/20 vision, but checking the periphery, I can see that area of white without pressure. And I want to see what the OCT wide field can tell. And it confirms there are no tractions, but the choroid is actually thin. Retina and choroid are just thin, but no threatening lesion. She had already a diagnosis of incontinentia pigmenti with genetic analysis. I observed that the wide field is very useful in meiosis. As any time when we have a shallow chamber, synechia, fibrotic capsule, and allergies to mydriatic drop or non-cooperative patients. Look at this patient. She has a shallow chamber. She doesn't like to be dilated, but she has a very interesting fundus. Is that a retinoschisis or detachment? We can check with certainty and see that she has a retinoschisis, and we check all the different areas in both eyes and have the confirmation of the diagnosis. In hazy media, it is very useful. We can see this young 8-year-old patient that I operated for retinal detachment after a cornea transplant. The view through the retinography and the direct view is very difficult, as you can imagine. But with the wide field OCT, I could see the detachment before the operation and the retina attached after surgery. And this is post-op. In high myopia, it is extremely useful in deep staphyloma, like in this patient. These are both eyes of the same patient. I can see the whole profile of the retina and check for lesions, like in this patient, still deep macular and papillary staphyloma. I can actually check with the wide field OCT that he has a macular hole and a double staphyloma in the macula and in the nasal area. The other eye has a shallow retinal detachment. This is pre-op and this is after macular buccal surgery. What about angio-OCT? This is an example of normal wide field angio-OCT. You will see now a fresh central retinal vein occlusion. It is very important to know if this patient has ischemic areas. Without fluorescein, we can check with the OCT that she has no ischemic areas. The problem is the macular edema that we can treat with injection. There is no rush for pump photocoagulation, and this is pre-op and post-injection. Another example, this is one eye with a normal angio-CT of one patient that has in the other eye this situation. So vision is 0.3, and with the OCT, I don't really understand why the vision is so low, because the macula does not look so bad, although there is a very thin temporal retina. But the angio-OCT shows with certainty the ischemic area, and the wide field OCT even better, the tremendous amount of ischemic areas in that eye that really needs pump photocoagulation as well. So here you see superimposed the angio-OCT to the color picture and the wide field OCT. It is a great guidance to interpret postoperative results. Look at this patient 1 day after vitrectomy. The fundus looks perfect with the bubble of gas still ongoing. But a few days after, the patient comes back with a drop in vision, and the fundus still looks very good. The wide field showed with certainty that he had retinocoroidal folds that I interpreted with hypotony for the reabsorption of the bubble. I waited for a few days, and the fundus was restored with the pressure. What about the anterior segment? The informations are enormous. Look at this patient with glaucoma. He came to me after complication of trabeculectomy in one eye. He had choroidal detachment, cataract, and what seemed new vessel and new vessel glaucoma, very shallow chamber. So I took him to surgery. This is the video of the first surgery. I removed the synechiae between iris and central cornea. This is the view through the intraoperative OCT that was guiding my surgery. I then removed the cataract, and then vitrectomy to release first the choroidal detachment. And I could check the retina, which was attached. The eye looked very well 3 days after surgery with aphakia, retina attached. But then a few days later, he came with very high pressure, and I did not understand why, because the iridotomy was open, the AC was deep, he was aphakic with no vitreous, so why? The OCT wide field of the anterior segment showed a veil of what I interpreted remaining vitreous, and also that the iridotomy was not completely open. So I took him back to surgery to remove those layers in the pupillary field and to reopen the iridotomy. I also implanted the lens, and the eye looked good. So it really guided my surgical decision. In optic nerve disease, we realized the importance not just of the width of the wide field, but also the depth. These are drusen of the optic nerve that we can see in depth. And this is a very young woman that came with normal 20/20 vision. She didn't know why she had problem, and only the visual field showed the dramatic loss of peripheral field. You can see this example of coloboma just to show you the importance of seeing the profile even in depth. That also in tumors is very useful. This is a bad-looking choroidal lesion that in the OCT actually does not look so bad. It has something like drusen, but no liquid, so it can be interpreted as a chronic nevus, while this lesion has threatening signs, the vicinity to the optic nerve and the presence of subretinal fluid. It is a melanoma that needs immediate treatment. And last example is this woman that was sent to me for maculoschisis due to a very small coloboma in the optic nerve. But when I did the wide field OCT, I discovered also that lesion in the macula. So the very small coloboma and fluid in the retina, which could actually be secondary to the optic pit, but we cannot exclude the influence of the choroidal lesion as well. So this is the final view of that case, which is very spectacular, although even the B scan is informative enough. In summary, I think that the wide field OCT is extremely useful to detect peripheral lesion that could remain undetected, to clarify the diagnosis of suspect lesion, to have information in depth, and to have information on ischemia, new vessels, and edema follow-up with angio-OCT, with information on the anterior segment, and especially in hazy media, non-cooperative patient, and in myotic eyes. Very good for telemedicine too. Thank you.